Good morning, Your Excellencies. I trust you're all doing well and in good health.
Indeed.
Sure. So I'll just go straight to my few questions, which would like to hear more from your end. We'll start with Your Excellency, Dr. Mpoki. We understand that Canada is among our largest bilateral donor here in Tanzania within the health sector, providing significant support in the health system strengthening, but also in sexual reproductive health and rights. We'd like to hear from you, you being our former permanent secretary, but also the former ambassador of Tanzania to Canada. What are the main focus areas of importance that we need to consider in strengthening our bilateral cooperation between the two countries? You're welcome.
Thank you very much. The blueprint for a relationship between one country and others depends on what is offered on the table. The government of Canada, as a matter of principle, is keen to see that the marginalized groups in society are taken well care of. And therefore, their interest is on women, children, and youths. The government of Canada has, over many years, supported the health sector in the country of Tanzania. And in the recent past, since the year 1999, they have consolidated their support through what is referred to as the Health Basket Fund, together with Switzerland, COICA, DANIDA, UNFPA, UNICEF, and the World Bank. This has been a portfolio that has looked into addressing the inequitable distribution of health services delivery in the country. And a majority of the work that has been done through the President's Office, Regional Administration and Local Government. Ideally, to make sure that services are provided that are effective, that are efficient, that are affordable. But at the same time, to ensure that people that suffer from diseases that can be prevented or treated are not left behind. So the whole essence of the Canadian government has been in looking in those things. Now, historically, there hasn't been any problem because there is usually a memorandum of understanding that is entered between those who give and those who receive. And so the work is along that chart. So that becomes the blueprint. However, the Department of Foreign Affairs, Trade and Development of the Government of Canada, through Global Affairs, which is the Ministry of Foreign Affairs, has gone out to get certain things done out of the Basket Fund framework to address specific issues that will not be included in the Basket Fund portfolio. So things like food security, things like education, women, children, youth outside of the umbrella that is covered by the Health Basket Fund, and providing capacity building to bridge the gap, depending on specific needs that are raised by the recipient countries. This is a dynamic process that gets reviewed from time to time, and in the process, improvements are done to make sure that what was left behind is included. But as a member of two major bodies in the region, the East African Community and SADC, the platform that Canadian government offers also allows for the region bodies to approach the government and support services that are in short funding through such bodies. So the SADC and the East African Cooperation. So in short, that is what is available from the Canadian government. But the Health Basket Fund ensured that there was improvement in service provision, improvement in collection of funds through incorporation of IT means of implementation. But there are also areas where they assisted us in infrastructure development. when we were building district hospitals and health centers, especially around the Lake Zone. A majority of the funding through UNFPA came from the Canadian government. There are also other non-state actors, I think, that have also played parts, but depending on the need. Like the United Nations High Commission for Refugees has benefited a lot from the Canadian government, and as a government, we oversee the implementation of such interventions.
Okay, thank you so much. Just one more question I wanted to hear from your end. We understand that the government of Canada, you've spoken about government of Canada, but we also have academic institutions from Canada, and some foundations have been providing financial and technical support in different aspects in the health sector and social welfare. Now, as we're moving towards achieving the universal health coverage for Tanzania, can you share your perspective where and what could be some win-win cooperation with Canada, that we can seize such opportunities? A few minutes.
Oh, thank you very much. The country of Canada is like a continent. It is 10 times the landmass area of Tanzania and more. It's 9.9 million square kilometers. It has 10 provinces and 3 territories. 90% of the population of Canada exists within 240 distance from the border of America to the north. So a vast part of that land is not inhabited by people. And their population as of this moment is 39 million. So when we look at such a country, there are many lessons that we can pick that can help us sell the agenda of universal health coverage, that we leave no one behind. Because of the vastness of the territory and the sparsely population that is distributed the way I've described, the 10% occupies places that we would find inhabitable and unreachable. But none in Canada suffers from unreasonable expenditure of resources to find health because of the principles that the government has put in place. Number one, their health insurance provides for people to join any. There are more than 19. And these provides access to necessary health services. The necessary health services are defined by the ministries of health in the provinces, because it's a federal government. So each province acts like a semi-autonomous entity. Institutions of higher learning in those institutions subscribe to the same philosophy. While the government has the Ministry of Health together with the policies and guidances, it is a responsibility of each territory, each province to incorporate and make sure that none is left behind. So the country of Tanzania has enjoyed enormous cooperation from those institutions by providing opportunities for study. There are several universities that have had long-standing relations with the universities in the country. MUHAS, for instance, School of Nursing was founded by a collaboration between Dalhousie University and MUHAS. McMaster has provided so many opportunities. University of Toronto, University of Calgary, and many others, including University of British Columbia, which is housed in Vancouver. Victoria University is another one, and there are many. I'm just remembering a few here. That provide opportunities for training on areas that are not offered locally. But when it comes to meeting the needs of the patients, telemedicine or the digital health platform has become a very, very important intervention that provides quality services to people that otherwise would not have managed to reach them on time and respond to such needs as they come. Together with diseases that are emerging and those that are re-emerging, they are covered through that way, while they are keeping in tune with what the WHO offers as a guideline for the World Health.
Just want to build on that a little bit, on the telemedicine, and you were the former permanent secretary. We also adopted similar program. What do you think are the obstacles or the challenges that we're facing, and your views? Very quick one before we proceed to Ambassador Makocha.
Well, I think we loved the title,
Yeah.
but the price behind the implementation was a serious challenge. When UNESCO offered us an opportunity to try the system with Ololosokwan Health Center in Serengeti, it worked very well, but we never sustained it because our resources did not just measure the gap.
Okay. Asante sana. Okay, now we go to Ambassador Makocha, Your Excellency. We know you are ambassador in Indonesia for some time now. What are the major achievements which you have gathered from Indonesia health system that we can adopt in Tanzania? But also, if there are any shortfalls, what should we avoid? Karibu.
Thank you very much. And first, I would like to thank you for inviting me. I cannot claim to be an expert in public health, but at least in international cooperation, I know one or two. So at least I can comment on that. Now, let me start with just giving highlight of what Indonesia is, so that it can give you an idea of the enormity of the challenge, to build a strong health system. It's the largest archipelagic state with 17,000 islands, and the population is about 270 million people. Now imagine delivering healthcare to 270 million people who are dispersed in 17,000 islands. It's quite a challenge. So they've had their own trials and tribulation in their attempt to provide health service to their people. And initially, because it's a federal government, so they decentralized the budgeting system for the health sector. They had a law where every province is required to use about 15% of their budget in the health sector. So they had the minimum spending on health sector. They had that legislation. But then the challenge was, to meet the thresholds because, of competing priorities. So it proved very difficult. So the net result of that was there were serious inequities, in the provision of health services. So you will find some of the provinces are way ahead of the others, and in some other provinces are very far and remote. So reaching them was very difficult. So what they did is, of course, they enacted a new law now, which they require what they call the performance-based budgeting system, and which was centralized. So the genesis of that is because they wanted at least to eliminate out-of-pocket consumption on health, and that improved a bit, and that we're talking about 2019. So, but one of the areas that I think we can take a lesson from them is that they also introduced a universal health care law in 2014, and they're quite successful in that. With 270 million people, they are covering about 215 million people, which is almost 81%. Of the people are covered with health insurance. Now they have their challenges in the sense of providing services to everyone, because as I said, it's a constellation of islands, and some of which are difficult to reach. So one of the key lessons that I think we can learn from them, the first is that on how they were able to implement the universal health care and the health insurance. But the key to success to that is they have unveiled what is called the Comprehensive Digital Health Blueprint, which lays, the groundwork for country to leverage on the healthcare, digital healthcare, to provide, universal, affordable, and equitable care to all. So digitization of the health ecosystem, that has been something that I think we can learn from that. And how they've been able to, to roll out health insurance to such large numbers within such time, I think is also another thing that we can learn. I think as my initial remarks, I think let me end there.
Thank you so much. That's very interesting. to learn more about Indonesia. That's an area that we need to see how best we improve our health cooperation as well. And just one question before we go to Ambassador Mavura. We understand you have worked with His Excellency Late Mkapa for 6 years as his personal assistant. After hearing the previous speaker, of course, Balozi Mpoki, highlight on different perspectives of the country-to-country cooperation, if His Excellency Mkapa was alive today, and do you think what would have been his views, particularly on the direction Tanzania should take as we plan and move towards executing the Vision 2050? What do you think would be his views?
It's almost an oxymoron if I say it's a difficult and it's an easy question. It's a difficult in the sense that you're asking me to wear his shoes. You know, he was someone who was very introspective in his remarks. So it's a bit difficult to wear his shoes, but I will try. It's an easy one because you want me to give sort of like a conjecture, so there's no right or wrong. And what I'm going to do is, having worked for and under him for, you said actually to be precise, is 7 years, let me use 2 of his attributes that I think will inform my conjecture. The first one is that, you know, he was an internationalist. So he had a fair appreciation of what the international cooperation can do to help us as a developing nation, you know, to meet our developmental aspirations. So he was an internationalist, so, you know, as a developing country, you know, we need to forge cooperation to help us to achieve our aspiration. Even in the implementation of the Vision 2050, we need to forge this cooperation. But the second attribute, and I think that is also very important, is that he was also a realist. A realist in the sense that he understood that there is no altruism in international cooperation. You know, you don't cooperate with each other for altruistic reasons. So everyone, that is to say, usually in international cooperation, there's no such thing as free lunch or free dinner. So for him, he always advocated for us to develop our own domestic wherewithal to implement this kind of visions. And he used one of the metaphor, I think that I will explain here to sort of like send home the point I'm trying to make. He said, because we were discussing about the Vision 2020, and you know that was his brainchild. And when we were discussing, I asked him about what he thinks on the implementation of the Vision 2020, what are the challenges. And he said, you know, the biggest challenge to me, I think, we did not fully appreciate how difficult geopolitics can be in the implementation of, you know, of our plans. So he said, I wish we could have paid more attention to geopolitics. And he used this metaphor, which stuck with me since when he spoke about that. He said, you know, our movement to, you know, to development is like a caravan that consists of elephants and rabbits. We are moving the same directions towards development. So the elephant, because of the sheer size, doesn't need to look around to see where he is stepping on, because he can just go and trample anyone else and can go. But for us as rabbits, you always have to be mindful to see where the elephant is stepping on, because for you, it's a matter of life and death. If you don't look at where the elephant is stepping on, you know, then he will trample on you and you will die. So the rabbits are us, the developing countries. So you might have a Vision 2050, and you might have programs that you think are implementable and that will help us to implement. But then you hit the geopolitics. You're told these programs are not, you know, friendly, they're environmentally unfriendly, they're unsustainable and all that. So what we need to do is to develop our own domestic wherewithal to implement those products. And then we can forge cooperation to support where we fall short of our resources. And just as a final point, I think We all know that, for example, the Julius Nyerere hydropower project.
Yes.
Everyone knows that was conceived during Mwalimu time, the idea. But the implementation was done during Magufuli. So, and this I'm leaving as a food for thought for everyone to think for themselves. Imagine if we had implemented Mwalimu Nyerere hydroelectric power project then, and we were able to draw this 2,115 megawatts of electricity then, where would we have been, in terms of the energy that was generated to help us with our development strategy? So it is very important to take stock of geopolitical dynamics, and then we should be able to see and find ways how we circumvent those dynamics. I think that is what he would say. Thank you very much.
Asante sana for the very thought-provoking views. A round of applause for him. So we just want to wind up a little bit and then we'll proceed forward to the audience. Just be ready with your questions or comments. We'll give time for that. Now we go to Your Excellency, Ambassador Mavura. It is reported that Korea is the top 5 leading countries in the world that provides financial support, either through ODA or grants for the health sector support globally. Understanding that recently there was also the first Korea-Africa Summit, which was held in June 2024, and there are key resolutions that emerged from the summit. We would like to hear your perspective. How and where do you foresee Tanzania is able to be a strategic partner in health in this endeavor? We could mention currently which are the areas, but also as we envision our journey towards 2050. Karibu.
Thank you, Dr. Helen. As you rightly mentioned, we had a Korea-African Summit, the first one in the history of relations between Korea and Africa. It was in last June, last month. And we had the privilege to have Her Excellency President Samia Suluhu Hassan representing our country to this summit among the 25 presidents who made it. One of the areas among the 7 priority areas that we agree between Korea and Africa is on health. So that's very likely that Korea wants to play a major role in health cooperation in Africa. They're already doing infrastructure here and there, but they're also thinking of doing going much more on the capacity building and training in areas of biomedics, but again, pharmaceuticals, another area they have an interest with, and diagnostics, which they're doing very well. But also working with the Africa CDC and other bilateral engagements. Infectious disease, one of the area. But for us, what is more important takeaway is during that summit, Korea agreed to double the ODA they're giving to Africa from $5 billion US to $10 billion US, of course. So these $10 billion US will be going to these 7 critical areas. Health is one of the area. Now, what is the stake for Tanzania? Luckily, Korea and Tanzania have a very good relations, and we among 7 priority countries of Korea ODAs in Africa. So we are standing a better chance. We are one among 7 countries in Africa, out of 54 countries in Africa, 55 countries in Africa, that are working with Korea on ODA. So we're receiving 70% of Korea ODA to Africa. So that is our position, number 1. But on terms of health, our engagement has been much more on the infrastructure so far. So you can mention Mloganzila Hospital, which is not known, and I see Dr. Magandi there. And then we'll mention now there's another plan to build Binguni Hospital in Zanzibar, 600 beds, equivalent to Mloganzila. And there's a project coming on Muhimbili, rehabilitation, renovation of Muhimbili National Hospital. So of course, with the Mloganzila, there's a program tied to it in terms of the capacity building of the human resource health that we have. And I know COFI, Korea Foundation for International Health, and also KOICA are doing a great job in terms of training of our people. Currently, there are 8 health professionals in Korea. I met them last week before I came here, who are undergoing 3-month training on health. But going forward, I would say we have not have a structured cooperation between our two countries on health. So far, it is health infrastructure. So going forward, the strategy should be now how do we, our two ministries of health, engage and have a comprehensive agreement on how to cooperate. And I give this example because the country like Saudi Arabia, since 2012, have a dedicated program to train their people in Korea for a long-term plan. And we can do that as well. So we are working and already have a consultation with the Office of the Minister of Health to see if we can have some sort of an MOU before the end of this year. And that will open the door now for a more comprehensive relationship in terms of health. But there's another potential which we have not explored, which is Korea NGOs as well. They're doing very well. So far, we have Africa Future Foundation, which is working at Mloganzila, and is the one who's supporting most of this training. But there's a lot of opportunity, and when you came to Korea, I introduced you to Korea Council Overseas NGOs, and last month they were here, and they visited you to do a mapping of a Tanzanian NGO CSO and see how well you can cooperate. They also have enough resources for this. So there's opportunity, there's more money, that's number one. Second, we are in the priority list anyway, even before that. So it's just a question of translating from infrastructure, health relations into a more comprehensive health engagement. Thank you.
Wonderful. Thank you so much for shedding more light of the opportunities in Korea. One question I also still want to get your views is related to the public-private partnership cooperation. We understand in any nation this is one of the critical ingredients for development, and similarly is the case on having a very robust health systems. We need to have the private-public partnership as well. So we'd like to hear your opinion. How best should we capitalize on PPP in strengthening health workforce, particularly from your understanding of the Tanzanian context and the learning that you've gained from Korea?
I should start by saying that one thing I appreciate being Korea at this point of time, Korea helps me to appreciate what we are doing. And I would say we are doing very right things in the very right direction. We might not see the end from where we are now, but whenever I explain to them what we are going through, they say this is what we were 20, 30 years ago. So we are in this very right track. They went through the same thing. And I would say, okay, I'll come to the lessons I've learned later, but let me go first to this private sector thing. In Korea, you cannot tell the difference between a private and public facility. The lines are very, very blurred. And 72% of people are actually attended by private facilities. Government actually caters for only 28% of people. So it is largely dominated private sector. But again, many people attended to clinics, and they're attending to private clinics actually, owned by professional doctors, but also attending to universities, hospitals, which are also privately owned. And the largest hospitals in Korea, the top 5, none of them is government. Most of them are privately owned. The first one is Assad University, which is owned by Hyundai. And then you have a Samsung University. Then you have a Korea University, which is private. And then you have Yonsei University, is private. So it's not even in Muhimbili. Even the Muhimbili is private. So because of that, private sector is important part of health care in Korea, and the government is working with them as partners, as equals. Thank you.
Okay, very interesting. Asante for those very honest views. I know we're running out of time. I just want to take a quick questions from the audience. I don't know, Chief Moderator, how do you do that? You have 2 people. Show of hands, or they've put on the notes? Okay, we'll start with the lady, Karibu. And I tend to recognize her. Please, can she have a mic? Karibu Prudence. we can go on forever here. So, yeah.
Thank you so much. Such a
Just keep it
fantastic-
short.
Thank you.
and
Thank you
concise.
so
Thank you.
much. We have learned a lot from our dear brothers. My question is to Ambassador Togolani, and I was so pleased to hear about Tanzanians going to learn there. But my question is, why not an exchange, us having the tutors or professors from Korea to come to our colleges like the students, because I know the students will go. When they come back, they come to the same systems. Well, if someone comes from that system, can somehow help us to change our systems as well. So should not go to learn, but as well as have those professionals to come and have that kind of partnership. Thank you.
Thank you so much, Prudence. Another question? Let's just take some more questions. 2 more questions. I can't see show of hands. How much? Please, there's one there. And then the boss, Dr. Mliga, who's that was professor? Karibu, you introduce and then proceed.
Thank you so much. My name is Dr. Matogoro from the University of Dodoma. And it's exciting to have the excellence sharing the experience. I would like to understand the extent of the adoption of technology, especially the emerging technology like artificial intelligence in the health sectors in those countries. Maybe we can get experience from those. Thank you so much.
Thank you so much. Next, Dr. Mliga. I hope you're taking notes of that.
Thank you very much, Dr. Mkondia. I'd like to ask Ambassador Togolani. It is very interesting that the health provision in Korea is very much privatized. And as for us, most of our health provision is carried out by the government. The challenge that I see there, which may not be, I don't know what the arrangements there are. How is the financing of the people who, some of them are very poor, and you know that private sector is usually profit driven. So how does the government of Korea ensure that the people, especially the poor, get access to health care provided by those private facilities? Thank you.
Thank you so much. Just, I'll give a special opportunity for a lady. If there's a lady who has a question. Please, Karibu. And feel free to use both languages, Swahili or English. Karibu.
Okay, thank you, Dr. Helen. My name is Marieta Mashimba, Health Administrator from JK Hospital. My question to Ambassador Togolani is, yes, is the collaboration of Tanzania and Korea on training, endorsement, and ensuring human resource for health skills. How do you strengthening training on private sector's human resource for health? Because the priority is given on to the government, but if we are going to strengthen quality of health care, we should make sure we strengthen public-private partnership as well.
Asante sana. Okay, so maybe we'll start straight with Ambassador Mavura Togolani, because most of the questions were channeled to you, but I'd like also to hear the views of other panelists as well, especially the technological issue. Karibu.
Asante. No, starting with Prudence. She wanted to understand why we talk only about sending our personnel to Korea and not the vice versa. I have 2 responses on this. The first one is already there are some Koreans who are coming here and working as volunteers. They're working under Koika program. And Loganzila is one of an example. They are coming here for a period of time, from different specialities to work here. So that is in a small scale that we are doing. And that's why, and this is actually part of the infrastructural sort of cooperation. And that's why I say the answer going forward is having a comprehensive cooperation on health with Korea. So we don't have such a cooperation, that's why they're not coming. But they are available and they're actually going to other countries. So this is something we're trying to emulate. This is something that I'm working on. But coming next week, I have a lecture of opportunity at MUHAS. And that's exactly the reason why I'm going there. Trying to understand what they're doing, but again, trying to present to them opportunities abound in this area so that we can look for ways to cooperate. Koreans are ready and doing that a lot, especially in Asia, but they're doing less in Africa. And to me, partly is because for a longer time, I mean, whether it's our diplomacy, even our sector of health, it has been much more Western. We are focused much more on Europeans and Europe and America. Simple. We didn't turn to this side. This is I'm trying to say, people. I mean, there's also another part of the world this side. So this is where we are going, and I see a lot of opportunity in this area. They are more than ready. Their government is financing a lot of the people to go out. They have a lot of retirees in Korea who are still healthy. They are living up to 86 years. They wish to go out under programs like that, but we need to have an embracing hands for them. So that's to you. To Dr. Matogoro, in terms of technology, I think I should also pass on that. Strangely, in Korea, there's a lot of uptake technology in terms of diagnostics. In the diagnostics area, technology is widely used. In the health information system, it's digitalized fully, widely used. And they have a culture that I like of having a shared infrastructure. The government put an infrastructure which can be shared by private sector and government sector. So you don't have to have your own health infrastructure system and then another hospital has theirs, another hospital has theirs, because the entry becomes very expensive if each hospital or each healthcare facility has to put its own infrastructure. So the government put the common infrastructure and the rest get access to it. So they're doing that very well. Telemedicine is something that they're not, the Korean Medical Association, the doctors, are not in favor of this. Because of course for them, they have plenty of doctors and plenty of clinics, accessibility is very closer, and they want people to come to be treated by them. So they are not very much in favor of telemedicine in Korea. The government is trying to move to that side, and during the COVID, it tried a lot to push that, but the Doctor Association, they are very adamant about it. And the Korea Medical Association and Korea Hospital Owner Association are very powerful institutions in terms of shaping what the government can do. So the government in Korea, especially in the health sector, doesn't have that much say on its own. It has to negotiate with its parties. In terms of, I think Dr. Mkonyi, if I'm not mistaken, asked about the financing.
It's Dr. Mliga.
Mliga.
Yes.
Mliga, about financing. Korea also is having universal health care, UHC. So there's 100% coverage on the health insurance. Right? Everybody is covered regardless. And they're using pension system, which is covering for everyone, but the government also offers subsidies to that. But Korea is a capitalist country, but when it comes to health, it's a very socialist country. Yes, the government is trying that at all the time, the cost of health is not skyrocketing that much. So healthcare is more of a service than a profit business. There's not about high margin, but it's a question of volume. So it's more of a volume rather than the high business. Of course, the consultation fees, for instance, are very low, but they capitalize on things like annual health checkup and other areas, cosmetic medicines and other type of those kind of services. So that should not be a problem. But another factor, which I think it's important to talk when we talk about health in this country, is education.
Yes.
We usually take health as independent from education. So Korean public is very educated. Average education is diploma. So what does it mean? A person who is more educated takes good care of health. follow much on the health directives. So people also don't fall sick easily and don't have to use these expenses every now and then. But also in the insurance system, they've made it in a way that is not cover you 100% all the time. So you pay, government will pay for like 85, you have to pay for at least 15%. And the idea when I asked, they said, if you make it free, people abuse it. Somebody having a headache in the morning and have a stomach ache in the afternoon goes to those 2-3 times. So you have to feel the pinch of paying a bit out of it so that you'll be responsible on how you're using your insurance. So this is what I've said. In terms of Dr. Mashiba, collaboration, not doctor, inshallah utakuwa. In terms of private sector, I would say it again, I said as in Korea, you don't see a difference between a doctor in private sector and doctor in public sector. Government cater, for them the important thing is true north. Whether you are in private, whether you're government, you unahudumia wananchi, you're just attending people. So, of course, it's unfortunate that private facilities in Tanzania will not want to train their people and they expect the government to do it. But fine, the government should do it anyway, if possible, because at the end of the day, the people who are saved are Tanzanians, whether saved in private or public facilities. So what are they doing? To them, they don't discriminate. You have funds for that. And I think what we can do is a question now. When we are not talking about cooperation with Korea on health, in our MOU, it is up to us, the government side, to decide whether we are going to, we'll open this to all, whether you are in private or you are in government. Like Samia Scholarship, I think is also not restricted, right?
Yes.
Thank you.
Thank you so much, Wellers Mavura. Maybe I just want to hear from Dr. Mpoki, Ambassador Mpoki. What's your view in terms of the PPP, private sector engagement?
I think it's one of the key interventions that can leverage available resources in bridging the gap, especially when it comes to funding. The infrastructure available, the playing field, and the consumption is readily available for provision of quality services that are affordable. Now that affordability is quote unquote, because quality behind it will determine what can be done. We are running the same race. We cannot entertain unproductive competition. If our nation is sick, the people of this country deserve the very best from the health experts, whether they are privately positioned or they are in the public sector. And so we just need to ask for a field that is going to be regulated in a sustainable way so that people who invest don't end up losing, because that is going to be a disincentive for them to be engaged. And this happens everywhere around the world. With the health insurance, companies that come, they could play a very, very pivotal role in ensuring that funding is not a limiting factor preventing our people from the catastrophic expenditures. Now, the lady who inquired about the training,
yes,
I think it's a double-edged sword. In the past, so many people were privileged to go abroad, they never came back. But we are seeing a majority of the people now training outside the country coming back to offer services. India is such an example of the countries that are benefiting a lot from the citizens that acquired knowledge abroad and they went back home and established world-class institutions where medical tourism is blooming. But we also have opportunities where entities from countries that are more developed than ours wanting to collaborate with our people. Last month, or early part of this month, the MDRM is an entity in Canada that came to MUHAS. And they took part in innovation co-creation workshop that was run by the university. This is going to form a building block for the implementation of digital health in the country. So that, like Muhimbili University is already placing in place mechanisms that will help our people to train, and once they graduate, they're going to employ what they learn in transforming the healthcare space. On the artificial intelligence, this is a very, very broad question. And I can't pretend that I'll have the answers to cover a country that is as big as Canada is. But there are a few things that I came across. And the first one is on forecasting population needs to inform planning, That is an artificially intelligent, motivated work. Identifying population groups with optimal needs that are not being met. The inclusion of populations that have been left behind for a long time. The Inuits, the First Nations, and those kind of people is done by artificial intelligence. And then integrating analytics and digital tools with electronic health records. On the consumption, on the planning, on the transformation, but also on the design for better health commodities, be they medicines or devices to help solve patients' problems in the nation. All these draw a lot from the artificial intelligence. That is as far as the health sector is concerned.
Okay.
But out there, you talk about de Havilland, Canada, you know, the Bombardier. The work that is being done there is done by robots, which is a product of artificial intelligence. Global Aircrafts, these are business jets. The parent company of what we fly in now employs the same. Airbus industry does the same thing. When you talk about the trains, you talk about the signaling systems, because trains in the world now, especially the city, for commuter trains do not have drivers. What runs those systems is artificial intelligence that tells the equipment to stop at a given station, the doors open, and when everybody has embarked, the doors close artificially.
Thank you.
So I think the sky is the limit.
Thank you so much, Belas Mpoki. And I know we'll be having some concurrent sessions today, which will relate to artificial intelligence and transformational technology, but also issues of PPP models. So please don't miss those parallel sessions. Final but not least, Ambassador Makocha, please just give you a few remarks regarding the whole aspects on technology. And because you mentioned Indonesia has a very constructive and advanced digital healthcare, please.
Yes, thank you very much. You know, moderator, I have an advantage here. I'm sandwiched by the ambassadors from developed countries, and I'm the only one from developing countries, so I can take refuge on that, because Indonesia is only coming out of age recently, about 10 years ago. Okay. But they're doing very well. So I think I'll only comment on the aspect of artificial intelligence. You know, because as I said earlier, yeah, for them, their sheer size and the population made it very important to have digital solutions to healthcare. Otherwise, they wouldn't have been able to reach to all their citizenry everywhere. So that's why, contrary to what my colleague Ambassador Togolani has said, for them they embrace very much telehealth, because they can reach to areas where people cannot access hospital care. So the comprehensive digital health blueprint has 3 aspects. It has the digital health records to manage a deluge of data that they have. But also the second component is telehealth, and the third component is artificial intelligence. Now, one remark I wanted to say, and which it dovetails very well with what I said about Mzee Mkapa, is that Indonesians, they want to develop everything themselves, and then they only go out to seek support when there is a need to. So I can tell you that all these digital systems that they're developing themselves. And if you remember, when the president of Indonesia came here for a state visit on August 22nd last year, we signed a memorandum of understanding with the Ministry of Health here. One of the components within that memorandum of understanding was on digitization of the health sector. They were ready to support us in the training on how to digitize the health sector, and I think that will help a lot. So to answer that question, I said artificial intelligence is one of the integral component of the digitization initiative that Indonesia is taking, and they're ready to share it with us, and it's actually part of the memorandum of understanding that we signed between us and them. Thank you very much.
Thank you very much. Just before we wind up, 1 minute for each one of you. Can we start with Ambassador Mavura, because we just need to wind up this session. It was quite interesting.
Thank you.
Yeah.
Just 3 points in 1 minute.
Okay.
Number one, I think we're doing good in terms of universal health insurance. In Korea, they started in 1977. It took them 12 years to achieve universal health coverage. So we should not be afraid of starting. So I commend the government, the President Samia Suluhu Hassan, Minister Umi for starting it. That's number one. We're in the right direction. Let's start. We'll catch up later.
Jamani, makofi basi.
Okay. Number two, building human resource for health is not linear. That's what I also learned in Korea. In 1970s, Korea, they trained nurses more than the facilities could take. So they took their nurses, they sent them to Germany to work. Later, their system improved and expanded. The nurses came back with experiences. So now we should continue to train doctors, we should continue to train nurses. Even if we cannot absorb them, let's find opportunities for them outside.
International recruitment.
Okay.
Please. Thank you.
Later, they'll come back here to work with even more experience. And third one, the human resource for health is a distance mirage. It's a moving target. Today, we may think that we can have quota. If we have this and this and this will be fully. That's not the case. Korea has 95% specialists. Some facilities have 2 specialists. 73% of facilities have at least 2 specialists. But today, Korea is suffering not having pediatrics simply because of the low birth rate. So less children. They're now struggling, and they're trying to increase the quota of getting pediatrics. So even if you attain the levels of Korea, you're not going to solve the HRH, human resource for health problem. So we should not be frustrated where we are. There's more we can do. It's a moving target, and we should be able to be agile. Thank you.
Thank you so much, Balozi Mavura. 1 minute, Ambassador Makocha, Karibu.
I will just give a one-liner. Strengthening of the health system, to me, I think, and most will agree with me, is predominantly a national issue. And I think that is where we should hedge our bets. And if there's one area that we can learn, the ownership of the health system strengthening, I think, is Indonesia, because, they guard that very, very jealously, because, they understand their own dynamics in the health system, and they therefore very jealously lead the process of the health system strengthening. And I think we can learn from them on that.
Asante sana. Makofi kwake. Please, my brother.
In the year 2018, the Ministry of Health drew a national surgical obstetric anesthesia plan for the country and costed it. We need to do a similar thing for the human resource for health, without forgetting that what we are doing today cannot answer questions that will exist 10 years down the line. So that must be factored in. Without forgetting to factor for those that retire, for those that die, and for those that move to other places for pastures that are not as exist in the country. But also, we have to remember that as we train, we impart experts with knowledge and skills, but they need cross-fertilization from places that offer better. So exchange program must be part and parcel of specialized and super specialized training if we are going to see the dawn of tomorrow in health sector. Thank you very much.
Asante sana, Balozi Mpoki. So just to wind up, what I'm taking up as key home messages which we need to take here is we need to invest on health diplomacy. And I'm glad we have our Deputy PS here from Ministry of Foreign Affairs and East Africa Cooperation. So we should explore more and more, have more MOUs between the Ministry of Health. But we are also realizing that digitalization of our health services and system is of paramount importance. It's more of emphasizing on that area. I really like the whole idea you mentioned about the performance-based budgeting system, which is coming from Indonesia. That's a take-home message. And of course, we realize HRH crisis is not unique only for Tanzania or developing countries. Even the developed countries have their own challenges which they've been addressing on human resource for health. Your honorable ambassadors, I highly acknowledge your presence, your views, your time, your thoughts, and great highlights that you've given us today. Asanteni sana. Asante. Thank you very much.